Welcome to Rehabilitation Sciences YouTube channel. And here today's lecture is on chest X-ray interpretation. And we have with us Dr. Bodhottom Banerjee. He'll be talking about this topic. And moderator today, Dr. Sagun Agarwal. He'll formally introduce faculty and start the session. Before we start session, Dr. Bodhottom, we would like to have your consent for making your lecture live on YouTube, sir.
Yes, please go ahead.
Thank you, sir. Dr. Sagun, you can start the session, sir.
For today's lecture, we are having with us Dr. Bodhottom Chatterjee. He did his bachelor's in physiotherapy from Bangalore and master's in physiotherapy in neurology from Kolkata. He is the gold medalist in fellowship in sports sciences from Apollo. He is currently manager in Department of Physical Therapy and Rehabilitation at National Ravindranath Tagore International Institute of Cardiac Sciences, Kolkata. Dr. Bodhottom is having more than 14 years of the clinical experience. We welcome you, Dr. Bodhottom, on Rehabilitation Science Group. You can continue.
First of all, a very good evening to everyone present here. At the very outset, let me extend my gratitude to the organizing committee of this group, which includes Dr. Sagun Agarwal, Dr. Dharam Pandey, and Dr. Harpreet Singh, for inviting me as a speaker for today's webinar and giving a gracious introduction of mine. Last but not the least, I would like to mention the name of Shobhik Roy, my friend. It is only because of him I'm here today. Without any further delay, let's start. We are already a little late. So X-ray is very important for physiotherapists, especially for those who are involved with critical care setups. Critical care setup patients, especially like cardiac rehabilitation, pulmonary rehabilitation, patients with pulmonary conditions like asthma, interstitial lung diseases, pneumonia, cardiac patients like those who has undergone cardiac surgeries. These kind of patients needs a lot of critical care physiotherapy on and off. So we require a lot of knowledge about the chest X-rays. That helps us to give accurate treatment to the patients, the best possible exercise prescription that we can give, and all it happens because the exercises are different from patient to patient and condition to condition. And another important reason behind knowing this is you can give proper handover to your colleagues, right? So what is an X-ray? X-ray is an electromagnetic radiation that we studied in our class 10 and 12 setups. There are a lot of electromagnetic radiations present in and around us. We have radio waves, microwaves, infrared radiation, visible light. X-rays is one among them. X-ray has got a definite wavelength and a definite frequency. The wavelength is around 0.1 to 10 nanometers. X-ray has got a unique property, and this property is that it can penetrate to the human body. And if you can keep a film on the opposite side, you get the images of the internal organs on that particular film. And this particular property has been used since ages by medicine doctors, radiologists to diagnose different kind of conditions and to treat certain conditions. So it is very important to learn about the chest X-rays. So now the world around us is very much colorful, but now next 1 hour, we will be going to see everything in black and white. So we have to remember a few things in our mind, that chest X-ray is two-dimensional representations of the three-dimensional objects. Two-dimensional representation means whatever you are going to see on an X-ray will be two-dimensional, but actually your heart, your lungs, your bones, they are three-dimensional in nature. So you have to consider this when you are dealing with the X-rays. The colors which you can see on a chest X-ray would be like this. Black, anything which is black is air, dark gray, light gray, off-white, bright white for the metals, right? So on the right side, I have given the colors and the specifications of this. Just you can look into this picture. It's the colors depends upon the density of the objects or the internal organs. The organs which are more dense would look whiter. That's why metal looks whiter. If the density of the particular object is less, if it contains air, then it will look black. And in between these colors will come, which are of lesser density or more density. Depending upon the density, you see the colors. So let's have a look into these X-rays. You can see this black color. This is the lungs because it contains air. Anything that contains air will be lighter in density and it will look black. This is the bright white color. This is a pacemaker implant. That's why it's a metal. It is looking bright white. You can see these bones, which are off-white in color, right? This particular area, you have the heart, which is gray in color, little light gray in color. If you have subcutaneous tissue, you get a dark gray color. So these are the colors that you can find on a chest X-ray. This is a lateral film. These are two AP and PA films. We will talk about these in the next slides. Look at this picture. You can see the bone, which is off-white. You have the lungs, which is black in color. The heart contains blood, which is light gray in color. Now, these are certain steps which are need to be followed when you are taking after interpretation of a chest X-ray. We will go one by one. The first thing doesn't require any kind of medical knowledge. You need to check the name of the patient and the date the image was taken, right? Next, we will talk about one by one. So this is the direction, which is very much important. From which direction the X-ray beams were projected is important. Here, you can see a patient is standing. The chest is against the film. So this is a PA view, posterior anterior view. The X-ray beams were projected from the posterior aspect and it gave a picture that is a PA view. In an AP view, here, a patient stands generally in the anatomical position and X-ray beams are projected from the anterior aspect. This is a lateral film where you can see the patient has put his both hands overhead and his left chest is against the film or the image receptor. Here a patient is lying in a supine position and X-ray beams will be projected from the anterior aspect. This CR is called the central ray, and generally the central ray should pass through the T7 vertebra in all the directions. We have got a divergent property of X-ray that we have to keep in our mind when we are interpreting the chest X-rays. What does that mean? That means this film, the distance between the film and the heart or the organs, if the distance is less, then you can see a normal size of the image. If the distance between this film and the heart increases, then you get a magnified or a false magnification of the image. This you need to remember when you are interpreting an X-ray. This is a PA film, posterior anterior film. You can see the patient is standing against this particular X-ray film. His anterior chest is against this, and the X-ray beams are coming from the posterior aspect. That's why you get a magnified, not a magnified picture. You get the actual picture. Whereas when he is standing, when his back is against the image receptor, then you get a magnified view of the mediastinum or the heart. Then certain positions are important, whether the X-ray was taken in a supine position or the patient was in upright position, like you and me sitting straight, right? So if it is a supine position, some of the patients are critically ill, they are very much sick, they cannot go to the X-ray department. So they are mostly in the lying position. Patients who are intubated, patients who are very much critical, those patients are getting AP X-rays or X-rays done in the supine positions where you get a magnified heart or a magnified mediastinum, right? Whereas when a patient is going to the X-ray department, you get a PA film, you get the actual size of the heart or actual size of the mediastinum. So these are some of the differences between a supine and an upright X-ray. So you need to find out and must know how to differentiate. In a supine X-ray, your lungs will look smaller in size because of the divergent property of the X-ray, which I have already spoken. So here is a film. If I ask you whether it's a supine X-ray or upright X-ray, so without any doubt, you can say this is a supine X-ray because the mediastinum is quite wider and your heart shadow is looking bigger in size. So this is a supine X-ray. Next, find out the difference between an AP, that is the anterior posterior, and posterior anterior view of the X-rays. So the main difference is, first thing that you have to keep in your mind is the medial border of the scapula. If you can find the medial border of the scapula over the lung fields, then you can easily tell that this is an AP film. Some of the other findings are your clavicle would look oblique. In the PA film, your clavicle will look horizontal. In the AP film, you can see anterior ribs very clearly. In the PA film, you can see the posterior ribs more clearly. And in the AP film, you will have a magnified heart and the magnified mediastinum. Whereas in the PA film, you just get the original picture. There will not be any false magnification of such images. Right? Okay. Then we will talk about certain important technical aspects. It's written RIP. Don't confuse with rest in peace. It is about rotation, inspiration, and penetration. The first thing is rotation. You have to find out whether the film is rotated or not. For that, you have to draw an imaginary line through the spinous process, and you need to measure the medial ends of both the clavicle. Suppose this is the medial end of the right clavicle, this is the medial end of the left clavicle. You draw two lines. If these two lines are equal with each other, that means the film is not rotated. Just look here. You see the medial border of right clavicle and medial border of left clavicle over here. The lines are drawn, but the distance is not equal. That's why it is a rotated film. So let's have a look into this picture. The medial aspects of the clavicles are visible. This is a pediatric X-ray. The head has come in between the lung fields. The baby was moving a lot. That's why this X-ray is completely rotated. You cannot even draw an imaginary line to the spinous processes. Rather, the spinous process is not at all visible. So it's a rotated film. Now let's talk about the inspiration. Inspiration means generally when an X-ray is taken, a patient is asked to take a long deep breath and hold. Then only the X-ray beam should be projected. Here, how will you know whether it's an inspiration film or an expiration film? You have to count the posterior ribs. So here are the posterior ribs: 1, 2, 3, 4, 5, 6, 7, 8, and 9, and here is the 10. So if your right hemidiaphragm is lying in between the 8th and the 10th rib, or it is intersecting in between, then it would mean that it's a inspirated film. On the right side, you can see these are the anterior ribs, which are obliquely placed. Freshers are having difficulty in finding out the posterior ribs and the anterior ribs. Sometimes posterior ribs are mostly horizontal, whereas the anterior ribs are obliquely placed. So anteriorly, the 6th rib should intersect with the diaphragm, and posteriorly, the 10th, 9th, or the 8th rib should intersect with the diaphragm. Then only you will say it's an inspiratory film. So it's written over here. Now let's have a look into this image. You can count these posterior ribs over here: 1, 2, 3, 4, 5, and 6. So neither 8th nor 9th or nor 10th is intersecting with the right hemidiaphragm. So we will call it an expiratory film. So this is how we decide whether it's a inspiratory or an expiratory film. Last comes the P, RIP. P is for the penetration. Penetration is also very important. We call it a soft film if the penetration is less or it is an under-penetrated X-ray. We call these kind of films are hard film if the penetration is quite more. So you can see the lungs are looking very black in color, whereas here the lungs are looking whitish. There is no abnormality, but the penetration was wrong in both these X-rays. So how will you know whether the penetration is right or not? In a normally penetrated X-ray, you are supposed to see the vertebral column in between the heart barely. But here on this left photo, you cannot see the vertebral column. But on the right image, what you can see the entire vertebral column as well as the interdiscal spaces, which is not supposed to be seen. So this is abnormal as well as this is abnormal. But in a normal penetrated X-ray, you will barely see the vertebral columns, right? Next. So here is an image. If I ask you it's a soft film or a hard film, you must tell this is a soft film because you cannot see the vertebral borders, vertebral column at all. Some of the important factors that you need to know when you are interpreting the chest X-rays, these are cardiophrenic angles, the angles that is formed between the heart and the diaphragm, the costophrenic angles which are formed between the ribs and the diaphragm. So here another picture where there is a blunting of cardiophrenic angle that suggests it's a pleural effusion. Sometimes you can see blunting of the costophrenic angles that suggests again a pleural effusion. So these things are very important to keep in our mind. Look at this image. You can see the costophrenic angle is blunted over here, whereas this side it is quite sharp. So that there is a blunting of the costophrenic angle that suggests again a pleural effusion.
Dear friends, stay together, stay tuned. There is some internet issues and it will be restored shortly. Dr. Bodhottam, can you hear me?
Yes, I can hear you.
Do you need any help?
Shall I continue? I am not able to understand what is the problem.
Okay, you can continue.
Okay, okay. Am I audible?
Yes, yes.
Okay, okay. So I was talking about the diaphragm. Here you can see a picture. We know the diaphragm, the right diaphragm is little above the left diaphragm. And how above is the diaphragm? That is important. So it should not be placed somewhere in between the interthoracic space of 3 or 4. So generally, a diaphragm is to be present between 1 and 1.5 centimeter above the left diaphragm. So this is how you can find out and measure the this difference. So you draw a line like this on the upper side and another line like this, and this difference should be between 1 and 1.5 centimeters. Another important factors when we are talking about the diaphragm is the dome of the diaphragm. You draw a tangential line or an oblique line and you name it A, and you join the costophrenic and the cardiophrenic angles, and this distance is again, it should be between 1 and 1.5 centimeters. In some of the conditions, what happens exactly is there is a flattening of the diaphragm. Some of the conditions you can get this diaphragm, the dome of the diaphragm can get bigger in size. So you need to have this kind of ideas. We'll talk about that. Next is the cardiomegaly. So sometimes you can see a very big heart. How will you differentiate? How will you tell the heart is bigger in size? For that, you need to draw two lines. One line between the right heart border and the left heart border. Another line between the transthoracic diameter of the entire thorax. So the A should be less than 50% of A should be less than the B. The length of A should be lesser than B, right? So this is how you can tell about the cardiomegaly. So there is a systematic analysis in an alphabetical order that we follow for assessment of this chest X-rays. A stands for airway, B for bone, cardiac cell house, D for diaphragm, E for edges of the heart, and sometimes it is called effusions. I mean, sometimes we tell about the effusions always. F is for the fields of the lungs, G is the gas in the fundus, H for hyla, I for the instruments. So here is a picture. When you look at a chest X-ray, it's not always you look at the lungs and the heart. There are so many other structures that you need to find out, and you need to have the ideas. You can have a look into this so that you can see every structure that you can find on a chest X-ray. Here, everything is written, but when you see, nothing will be written. You have to have the knowledge to differentiate and find out the exact locations and exact organs which you are seeing. So here is the trachea, the A. A stands for airways. Here is the airway. So what are the things that you need to think and see in an airway? In some of the diseases, some of the conditions, your airway can get shifted towards any one side. If it's a lung collapse, where there is a volume loss, your trachea will be shifted towards the lung collapse. If it's a pleural effusion or it's a big pneumothorax, your trachea will be shifted away from the condition. Contralateral shift will happen. There is another angle which is important. This particular angle is called carinal angle. This is the angle should be between 60 degrees and 100 degrees. If you find there is any in, increase in this angle, then you can suspect some of the abnormalities. Generally, this angle increases if there is any enlargement of the right, I mean the left atrium. There can be an lymphatic enlargement or a nodule, or even a simple left upper lobe collapse will increase this particular angle, the carinal angle. When you're looking after this airway, you need to look after the around of the airway, that is the mediastinum. Sometimes you can see a wide mediastinum. Mediastinum can become wide if there is any trauma, if there is any hemorrhage, if there is any aneurysm of the mediastinal vessels, if there is any mediastinitis, that is the infection of the or inflammation of the mediastinum, all these conditions of there is a tumor in the mediastinum can make or widen the entire mediastinum, right? So these are the things that you need to see when you are looking after the trachea or the airways, right? Next comes the B. B is for the bone. What all you see? There are so many bones you can see: the ribs, the scapulae, the shoulder joints, the clavicles. You need to check about these dislocations, subluxations of the shoulder joint, any fractures, any osteoblastic or osteolytic lesions. You can find these kind of structures on an X-ray. So you need to have a proper knowledge about all these things. C is for the cardiac cell house. What is this cardiac cell house? Cardiac cell house is the absence of these borders. If you cannot find this right heart border, or if you cannot find the left heart border, all this aortic knuckle or this pulmonary trunk, that means there is some kind of abnormality over there, and that means that the cardiac cell house is positive. If you cannot find the dome of the diaphragm, then again the same language will be called diaphragmatic cell house is positive. So Silhout means absence of the normal structures, right? Then we have D. D is for the diaphragm. We have two domes, the right hemidiaphragm and the left hemidiaphragm. We have already spoken when we are talking about the diaphragm. We need to be very much clear about the costophrenic angles, the cardiophrenic angles, the dome of the diaphragm. We need to see whether there is any flattening of the dome or any enlargement in the size of the dome. These are the things which are very much important, right? E is for the effusion or the edges of the heart. Edges of the heart we have already spoken. E is the effusion. If there is any effusion, pleural effusion, then the first thing that will happen is the blunting of the costophrenic angles. And even the cardiophrenic angles can get blunted. So you need to know all those structures. F is for the field of lungs. The entire field of the lungs you have to see. It starts with the epiphysis here and the bases. You need to see whether you can see the epiphysis of the lungs and the bases clearly or not. You need to see, is there any kind of infiltration, any opacity, any spots, or any kind of uh, abnormality, any of the structures. Then you have to locate that particular that area, whether it's in the upper zone, it could be in the middle zone or in the lower zone, it could be in the right side or left side. You need to know where exactly is that particular location of that infiltrate or opacity. Then opacity pattern is important. It could be nodular, small circle-like structures. It could be reticular, mesh-like structures or line-like structures. So it can be the mixture of both, reticular, nodular. So those ideas are important when we are checking on that. G for the gastric bubble. G stands for the gastric bubble. If you see a gastric bubble just below the left diaphragm, this is absolutely normal. But if you see that gastric bubble somewhere else below the right diaphragm, then it is abnormal. That could be because of pneumoperitoneum. Or you find a gastric bubble somewhere here, then it is an abnormal. We'll talk about those things later. Then I stands for the instruments. Instruments means it could be an endotracheal tube, it could be an intrathoracic drainage, it could be a pacemaker implant, and any kind of plates, screws, K wires, mediastinum wires, and so on. These are called the instruments. So the same thing here. And this H stands for the hyla. Hyla is a very important point where this main bronchus enters your lungs, the pulmonary artery enters, and pulmonary vein comes out of this area. So this hyla, the left hyla is little higher than the right hilum, and it is generally concave. So we need to remember that there is a concavity, and the density of these two areas need to be the same. If there is any change in the density, any abnormal opacity if you find, then it would mean that there is some issues with that particular hilar point. So we need to keep this in our mind. So in radiological findings, generally the lungs is divided into zones, into 6 zones. So upper zone, middle zone, and lower zone, upper zone, middle zone, and lower zone on the right and the left. And how do you divide it? You divide it through the ribs, the anterior ribs. The first two anterior ribs will make the upper zone, next two anterior ribs will make the middle zone, and the next two anterior ribs will make the lower zone. This is how you will make the zones. So when you are asked to find out what is the abnormality in a chest X-ray, you have to answer these 7 questions. If you can answer these 7 questions, your interpretation is going to be near normal or absolutely normal, right? So what are these 7 questions? First, where is the lesion and what is the lesion? Where is the lesion? Which particular tissue is involved? Whether lung, heart, or bone? Which side? Whether right side or the left side? Which particular zone?
Darwaja.
On the Then we talk about the size of the lesions, the number, it could be 1 or more, shape of the lesion, rectangular, wedge shape, or which particular shape, the edges are smooth or irregular, pattern is nodular or reticular nodular. You have different kind of densities like air, blood, and bone densities, distribution, whether it's a focal or wider spread. So these are the questions that you have to answer when you are asked to interpret an X-ray. Let's talk about the condition that we come across on a daily basis. The physiotherapists who are working with patients who are critical, we come across these kind of conditions. First, talk about the lung collapse. Let's see the picture, and we will talk about that. Lung collapse is the loss of volume. Why it happens? Because it happens of 2 reasons. One is the obstructive reason. There is any obstruction in the main bronchus or any of the bronchus or any of the airways that leads to a collapse. This obstruction can be a mucus plug. It can be a small food particle for a pediatric case. It could be even a toy can obstruct the main airways. Then the remaining airways is going to collapse. There can be a tumor in the airways or around the airway that is compressing the airway. All these kind of conditions can lead to a lung collapse. These are obstructive reasons. There is a non-obstructive reasons. What are the non-obstructive reasons? There can be a pneumothorax that is compressing the lungs. There can be a large pleural effusion that is compressing the lungs. There can be a tumor that can also compress the lungs. So these are some of the non-obstructive reasons that can lead to lung collapse. First thing we know, the right lung is supposed to be big in size than the left lung. The right diaphragm is supposed to be a little above the left diaphragm. So if something opposite happens, then you can guess that there is a lung collapse. Let's discuss about this picture. Here you can see the right lung is very big in size. There is flattening of the diaphragm. You cannot see the dome of the diaphragm over here. The left lung is looking whitish. It has got collapsed. There is shift of the trachea, which I have already spoken. The trachea has got shifted towards the left collapse. The mediastinum to some extent has got shifted to the left side, and there is a loss of volume. You cannot see the aortic knuckle even properly. Let's look into this picture. There is overcrowding of ribs. It's not like that everywhere you will see all the findings. Somewhere you can see some set of findings, somewhere you can see some other set of findings. But here, you can see the entire right lung has got into collapse. The trachea got shifted, the mediastinum got shifted. There is crowding of ribs. You cannot see the diaphragm, and things are not visible. The hard borders are absent, so you can tell that this is a lung collapse. Let's talk about pleural effusion, very commonly found in an intensive care unit. There is an accumulation of fluid in the pleural cavity. What exactly happens? We have visceral pleura and parietal pleura. The distance between the visceral pleura and the parietal pleura is less anteriorly and posteriorly, but laterally the distance is quite more. So generally, this fluid gets accumulated in the dependent area of the lungs. That's why the claustrophrenic angles are blunted. But as soon as this fluid goes up, and up, it gets gradually collected into the anterior and posterior aspect. And what you see a meniscal sign, a concave upper border sign, which is called meniscal sign. Look at these pictures. Here, there is a pleural effusion. You cannot make out the claustrophrenic angles. You can see a concave upper border over here, and there is no shift of trachea, or the mediastinum is quite normal because this fluid is not much. It is less. So this meniscal sign proves or tells that this is a pleural effusion. On this side also you can see this meniscal side, a concave sign that proves that there is an accumulation of fluid which is gradually getting tracked into the lateral aspects of the chest or the pleura. Over here, this size of the pleural effusion is quite big. That's why there is a shift of the trachea. There is a shift of the mediastinum as well. That's why you can see this particular finding as a finding of a pleural effusion. Here also, this very big pleural effusion. The trachea has got shifted towards the right. You cannot see anything on the left side. Next, we talk about the pericardial effusion. Sometimes effusion or this fluid can get accumulated in the pericardium. We know the coverings of the heart. We have endocardium, myocardium, pericardium. Pericardium also has got two layers, the visceral and the parietal. So in between this space, sometimes accumulation of fluid happens. Well, how will it look? It will look all of a sudden, you will see a very big size of a heart. We call it a globular heart. You can see, because there is a fluid, it's going to compress your heart and the cardiac output is going to drop. So it's a life-threatening condition, but it can be suddenly diagnosed. You are checking after a patient every day, you're checking the X-rays, X-rays are absolutely normal, but suddenly you see such a big heart. Even you can find that the hilum, which I spoke earlier, you cannot make out the hilum over here. Where is it, the hilum? Because it has overlapped the entire hilar spaces and your heart is looking very big in size. Now let's talk about this consolidation. We have a lot of issues with COVID at present. So these COVID patients are developing with pneumonia. They are coming to the hospital with pneumonia, and the particular name, the term is COVID pneumonia. If it is consolidation, you have to consider pneumonia. If it is pneumonia, you have to consider consolidation. So consolidation is something which is very important to understand, to find out, to interpret in a chest X-ray. What exactly happens in a consolidation is that the normal extensibility of the lung tissues are lost. As the name suggests, solidation, sometimes these lung tissues are becoming hard. There is swelling over there, and gradually the capacity to inflate and deflate is lost. That's why this consolidation happens, and these air cavities are replaced by liquids. These liquids could be pulmonary edema, inflammatory exudates, pus, inhaled water, whatever. Let's have a look into the consolidation, how it is going to look. We need to remember a few things, that in consolidation, there will not be any kind of shifts. Your trachea is not going to shift. Your mediastinum is not going to shift. There will not be any volume loss. Your lungs will be of same size, or in some cases, you can expect that the lung volume might increase, but there will be opacity. There can be blunting of claustrophrenic and cardiophrenic angles. You might not be able to see the hard borders, which we call a cardiac Silhouette sign positive. Diaphragm may you can see, you might not be able to see, but mostly you will not see any kind of volume loss. And the most important hallmark sign of consolidation is the presence of air bronchogram, which is nothing but a black tubular structures within the areas of consolidation. What exactly happens? The alveoli are filled with fluid. Alveolar sacs are filled with fluid, but the terminal bronchioles, which were containing air, are still containing air. That's why the surrounding is collapsed. The surrounding is fluid, filled with fluid. That's why it is looking white in color. Whereas the terminal bronchioles, the tertiary bronchioles, they are filled with air. That's why it looks black. So you can find air bronchogram, especially in the consolidation. It's a hallmark sign of consolidation. Let's have a look into these pictures. So this particular area is consolidated. The left lung, there is no shift of trachea, neither the mediastinum. You can see opacity over the left lower zone, the lingula. So on this, you can see the right middle zone has an opacity. And if you see minutely, you need to have an experienced eye to find out, you will see air bronchograms over there. Same here, the left lower zone has got a lot of opacity, and though there is no volume loss, right? So these are the pictures of consolidations. Pneumonia is something, it's an infection of your lungs. This infection can be caused by bacteria, can be caused by fungus or virus. At present, it is virus, that has brought so many patients to the hospital, and we all know about the name of the virus. It's COVID-19, right? So what exactly happens when there is inflammation in the air sacs of your lungs and in the alveoli? That leads to accumulation of pus, accumulation of fluid inside your alveoli or the air sacs. And you see pictures like this. Again, as I said, consolidation means pneumonia, pneumonia means consolidation. They're all correlated. So consolidated pictures and these pictures are going to be same. Little bit of information I would like to give about the COVID pneumonia X-rays. First, CT thorax is highly sensitive as compared to the chest X-rays. So most of the patients, if you want to find out any initial abnormality, or if you want to find out any suspicious case of COVID-19, it is always a CT thorax. It can detect even on the early symptoms of onset. You can see differences in a CT thorax. Whereas on a chest X-ray, in the initial stages, it's going to be absolutely normal. 69% of the patients who are getting hospitalized are having some of the abnormalities on a chest X-ray in the initial stages. 80% had abnormalities during hospitalizations, and most extensive findings are between 10th and 12th days of symptoms onset. So these are the things that we need to keep in our mind. X-rays in the initial stage of COVID patients will not have much of abnormality, but gradually these patients will get a lot of changes in the chest X-rays. So what are the changes that you can see or expect on a chest X-ray or on a CT thorax? So these are the changes. Air space opacity. There will be opacity, consolidation, and GGO, that is ground glass opacity. The name is ground glass opacity. You can find out on the chest X-rays. Distribution is going to be multifocal, everywhere, spatially bilateral, peripheral, and lower zones are predominant. During this particular infection, it starts with the lower zones, starts with the periphery, spreads bilaterally, multifocal. So it needs a proper treatment, otherwise it's going to invade the entire lungs, and gradually the patient is going to land up in ARDS, and we might lose the patient. So these are the pictures of COVID-19, or simply they are pneumonias. You will not see any volume loss. You will not see any tracheal or mediastinal shift. What you are going to see is opacities here, left upper zone, left right lower zone. You have right lower zone, and these are the areas. And if you minutely see, you will see air bronchograms over there, because these are consolidations. As I was talking about the ARDS, it is the acute respiratory distress syndrome. Patient comes to you with pneumonia. Suddenly he collapses and he is transferred to the intensive therapy unit. He needs ventilation because he has suddenly developed an ARDS. It can happen because of pulmonary conditions like viral pneumonia, like, or any inhalation of poisonous gases. So these are the conditions that can lead to ARDS. Some of the non-pulmonary conditions are septic shock, septicemia, pancreatitis. Sometimes a patient with cardiac surgery has landed up in ARDS. Anything, a road traffic accident, trauma to the chest can also lead to ARDS. But today, in the COVID scenario, patients are coming to us with pneumonia. Suddenly, they are collapsing, getting transferred to the ventilators or the intensive therapy unit. And after 2 or 3 days, we are losing the patient because there is inflammation of the airway sacs, and the diffusion of air or diffusion of gaseous exchange is absolutely stopped. The alveoli are filled with fluid, and the gaseous exchange absolutely stops, and gradually there is hypoxemia. Even if with a lot of ventilation and positive pressure airway, we cannot prevent, and the patient expires most of the time. So this is the picture of ARDS. You can see the endotracheal tube. The patient was ventilated, little similar with the pneumonia, but it will be widely spread, multifocal. Everywhere you will see white patches, right? Let's talk about this condition, pneumothorax. So if there is air in the pleural cavity, we call it pneumothorax. Gradually, if it increases, it's going to push or compress your lungs that can lead to lung collapse. So what are the reasons? It could be a chest injury. It could be because of a surgical interventions. There can be an emphysematous bullae. Patient coming to you, suddenly you take an X-ray, you see a pneumothorax. The patient had an emphysematous bullae, got ruptured. Then they are ending up with pneumothorax. Let's see the picture. How do you see a pneumothorax? Look at this. This is something abnormal. The lung border, the lateral lung border has come and it is sitting on the field of the lungs, right? This is not supposed to be seen. And there will be absence of bronchovascular markings because there is air everywhere in the pleura. There is no bronchovascular marking seen. The entire lung has collapsed, right? So these are some of the findings that you can see in a pneumothorax. So suddenly if you see any kind of lung borders in the middle of the lung fields, then you will consider it as a pneumothorax. Heart and tracheal shape towards the contralateral side. Of course, if it is pushing your lungs, it is going to push your trachea and then it is going to push your heart further. Next, surgical emphysema. This is a condition when you can find air or gas within the soft tissues. Some of the causes are tracheobronchial perforations, where there is gas leakage, penetrating traumas, surgical interventions, intubations, positive pressure ventilations, overinflation of endotracheal tube. These are some of the common causes that might lead to surgical emphysema. So how will be the picture? Look at this picture. There is sun rays appearance everywhere, isn't it? You can see black and white lines on this particular X-ray almost everywhere, right? Then you go to the patient, you will see there is a swelling of the face, swelling of the upper body, the anterior chest, the posterior chest, even the arms will be swelled up. If you touch them, what you will see? You will feel the crepitations, the coarse crepitations you can feel because the soft tissue is completely filled with air. So if it's a surgical emphysema, you can see a picture like this. You have to remember this. COPD, chronic obstructive pulmonary disease. They require a lot of pulmonary rehabilitation. They come to us for pulmonary rehabilitation. What are the findings in the COPD patient? Your lungs are overinflated. There is trapping of air in the alveoli. So your lungs will look very big in size. If they are very big in size, definitely your diaphragm are going to be flattened down and it is going to push your heart and the mediastinum. So the first finding is flattening of the diaphragm. Second finding would be tubular heart. Then you can see an hyperinflated lung fields. You see increased intercostal spaces. So this is a hyperinflated lungs, and we will call it a COPD lungs. Certain more conditions, pneumoperitoneum, presence of gas in the peritoneal cavity. I said when I was explaining initially that you will see a gaseous bubble on the left, below the left diaphragm, the hemidiaphragm. But if you see a gastric bubble below the right hemidiaphragm, then this is something abnormal. We call it pneumoperitoneum, right? This, here it is a small pneumoperitoneum. On this film, you can see it's a very large pneumoperitoneum. Exactly what happens, there is perforation of the abdominal viscus. It could be because of the perforated ulcer, perforation of any part of the bowel, benign ulcers, tumors, or trauma that can lead to a situation like this. So you have to be very careful when you are interpreting an X-ray. If you find something, a gaseous bubble on the right side, it could mean it's a pneumoperitoneum. Next, let's talk about the pneumomediastinum. So mediastinum is the space between these two lungs where the heart is situated. So any kind of black shadow is abnormal in the mediastinum. If you find it, then it would mean there's a pneumomediastinum. Another sign is continuous diaphragm sign, where you can see both the diaphragms are getting intersected with each other. So any gaseous bubble present in the mediastinal space would be called as a pneumomediastinum, and these are some of the causes. There can be leakage from the lungs from the trachea, central bronchi, esophagus, or peritoneum. Penetrating chest traumas, neck, thoracic, retroperitoneal surgeries, esophageal perforations, tracheobronchial perforations, ILDs, asthma can lead to hilum rupture, that can leak air into the mediastinum. This is a picture of pneumopericardium. We talk about this is pneumopericardium, air in the pericardium. See, you can see a black rim just surrounding the heart on both the sides. That means there was a leakage and air got trapped inside the pericardium. That's why it is looking. Again, if gradually the pneumopericardium increases, it's going to compress your heart. So you have to be very careful in finding this. Hiatus hernia. This is another condition. If there is any leakage in the diaphragm muscles, especially in the hiatus esophageal region, where the esophagus comes down through this diaphragm, that particular region can become weak. It can because of the aging, because of pregnancy, because of high strenuous work, where the intra-abdominal pressure increases, the abdominal content can be herniated through that particular space into the above the diaphragm, and that particular diaphragm, the abdominal content might be found just in the posterior aspect of the heart. Then this particular condition is called hiatus hernia. And how the picture is going to look like. Look at this picture. You can see a big hiatus hernia present just behind the heart. This is a semicircular line, but you can see something which is black over here. This black means air. This is air, and this is also air. Since this image has overlapped over the heart, that's why this looking little lighter in shades as compared to the blackish shades. So this is the diagnosis of hiatus hernia. If it is a small hiatus hernia, you may not make out in a chest X-ray. But since it's a big hiatus hernia, you are able to make out on a chest X-ray. So it's a retrocardiac location, round and well-defined walls. Now I spoke about a lot of things. The time is short. One by one, we will talk about this and we will end this particular presentation. So we need to remember this particular 10 steps before interpreting any chest X-ray. What are these steps? Where is the lesion and what is the lesion? So look at this image, this X-ray image on your left. Let's discuss. Where is the lesion? Can you tell me where is the lesion? Of course you can tell. Here is the lesion, isn't it? Everywhere the lung fields are normal. But if you check this particular area, you can see an opacity. So tissue involved here is lungs, right? Which side? Is a right or a left? This is a right side, right? Then which zone? Upper, lower, or middle? This is the lower zone of right side of the lungs, and the lungs is involved. So you have answered all the 3 questions. Now next, come to these 7 questions. Size. Can you tell me the size? It is around 3 centimeters in length and around 3 centimeters in width. It's a square or a rectangular shape, and this would be the size. The number is only 1 lesion. The edge seems to be irregular. There is no regularity. Seems to be irregular. The pattern over here is somewhat nodular. The density, whether it's air, no. Air means it should be black. Whether it's bone, no. Here it's not bone. Is it water? Yeah, there can be water. It could be pus. It could be inflammatory exudates. So you have answered this. It's water. Then the distribution is focal or wider spread. This is a focal spread of the distribution. So you have answered all these 10 questions. So now you have to tell what is this lesion. For I'm going to tell you, this is nothing. It's a pneumonia of the right lower zone, right? Next, see other pictures and try to understand. This is another picture. What is here? See, everything is clear, but something is missing. You cannot see the right hard border. You cannot see the diaphragm. Rather, the diaphragm has gone little up. The trachea is shifted towards the right side. There is intercostal drains. The left lungs is looking hyperinflated. as compared to the right lung. What does that suggest? That suggests it's a lung collapse on the right lower zone, right? So this is how we make out and tell, and this is a lung collapse. Next picture. What is this? You can see a concavity on the left side. I spoke about concavity. You cannot see the claustrophrenic angles on the left side. Even the right side, the claustrophrenic angles are blunted. So first thing that comes to our mind, that it's a pleural effusion. There is absence of claustrophrenic angles. There is a meniscal sign present. The left heart border is absent, or cardiac Silhouette sign is present, and we will tell that this is a left pleural effusion. But you cannot see any shifting of trachea or mediastinum over here, right? So we will call it a pleural effusion of the left side. This picture, again, this is a picture of a small baby. You can see a lot of rotation. You can see the endotracheal tube which has come up here, completely distorted view. Can you see the left lung? Can you find the left lung? No. So the left lung is missing. Can it be missing? No. This is a collapse of left lung. First finding. Second finding. What is this? I told you, you are seeing the border of your lungs. The border of the lungs is not supposed to be seen in the middle of the lung fields, but you can see the border of the lungs. There is no bronchovascular markings here. What does that suggest? That suggests it's a pneumothorax. The air has entered into the pleural cavity. It has pushed your lung, and the entire lung has collapsed. And this particular part has been occupied by air. So it's a right pneumothorax as well as left lung collapse, and there is a major collapse of the right lung as well. So this is a picture of a pneumothorax. Let's see this picture. We spoke about surgical emphysema. It happens because of surgical interventions or many other conditions that we already spoke. What we see sun rays appearances everywhere. So in this particular film, you can see sun rays or alternative white and black rays appearances everywhere. I spoke, if you go near to the patient, you will see there is a swelling of the face, swelling of the anterior and the posterior aspect of the chest. If you touch, you get a lot of coarse crepitations. So this is how you can suggest, or you can tell that this is a surgical emphysema. Right? Next we will go. See, look at this X-ray. It's looking hyperinflated. There is a flattening of diaphragm, right? There is a increase in the intercostal spaces. The heart is looking tubular in shape. Look at this picture again. The heart is tubular, right? What does that suggest? That suggests it is a picture of COPD, chronic obstructive pulmonary disease, because the entire lung is filled with air. Air have been trapped, and the entire lungs is looking very big. It has compressed the mediastinum. It has compressed the lungs. I mean, the heart. That's why the heart has become tubular in shape. Flattening of the diaphragm, increased space between the intercostal margins. So this is a picture of a COPD. Look at this picture. What does that see? See, this is the right side. It is written R. That means this is the right side. But there is an abnormality. It's not an abnormality, but it is something which I did not speak about. See, you can see the apex of the heart on the right side. So it's a dextrocardia. If you are seeing the apex of the heart on the right side accidentally, then you have to say that this is a dextrocardia. Not abnormal. It is absolutely normal. Sometimes you can see this like this. If you see the apex of the heart on the right side, it's a dextrocardia. So it's a film of dextrocardia. Let's see these pictures. I spoke about how to analyze where is the lesion, what is the lesion. These are the two questions that you should ask yourself and try to find out the answers. You will be able to interpret. Over here, you can see where is the lesion. Both the lungs has got the lesion. The left lung has got more lesions. The upper zone is completely white, opaque. You can see black tubular lines over here. What does that suggest? It's a air bronchogram, and this opacity is because of the consolidation. So the left lung is consolidated. there are air bronchograms, but you can see the diaphragm, the volume of the lung has not lost. So I already spoke. There will not be any tracheal shift. There will not be any mediastinal shift. There will not be any volume loss, but there will be opacity. There will be presence of air bronchograms. This is how you can tell that this is a consolidation. So this is a left lung, it is a consolidated. The right lung, the right image is a normal image. So you have to compare these images, and now I hope you can tell that this is a consolidated X-ray because there is no volume loss and presence of air bronchogram. Okay, next. Look at this picture. Is there any abnormality that you can find? Of course, yes. Gastric bubble beneath the left diaphragm is normal. Gastric bubble beneath the right diaphragm is not normal. We studied about this condition. It is pneumoperitoneum. That's why this gastric bubble you can see, which is an abnormal. If you find any gastric bubble, any gaseous image, here in the mediastinum, we call it pneumomediastinum. Here you call it hiatus hernia. Here it is pneumoperitoneum. So these are some of the common terms that we use when we are interpreting a chest X-ray. This is something new which I didn't speak about. This is a picture of hydropneumothorax. You put water in a bottle, half water. So what will you see? You will see there's a horizontal line over the water. Why? Because in the bottle you have air as well as you have water. The density of air and density of water, there will be a line intersecting between these two. So that line would be horizontal, absolutely horizontal. So something, when you can see something like this, a horizontal line on any side of the X-ray, then you should call it a hydropneumothorax. There is air as well as water in the pleural cavity that has led to this kind of picture, right? So this is another finding, hydropneumothorax. So by this, I am ending my presentation. Thank you.
Thank you, Dr. Bodhottom. It was with so many images and with so much experience across your practice, I feel that you have given a beautiful insight on interpretation of chest X-rays. And I must appreciate the 10 points that you mentioned for interpreting an X-ray. Where is the lesion? What is the tissue that is involved? And I think these steps of interpretation are important for every professional, not only students of physiotherapy, but for every professional. Dr. Bodhottom, do you feel that it is very difficult to interpret a consolidation and a collapse if it is not of the whole lung, but of a segment or a zone?
No, the main difference between a consolidation and collapse we have to keep in mind is the shifts. What can shift? In a collapse, your trachea can shift. In a collapse, your mediastinum can shift. In a collapse, the horizontal fissures or any of the fissures can shift. But in a consolidation, there will not be any shifts. This is the first difference. Next, of course, sometimes there is difficulty in finding out the differences. For that, we need to have other tools, like we need to do an auscultation, we need to do proper inspection of the patient, we need to go for diagnostic percussion over the chest walls, because consolidation will have a bronchial breath sounds, whereas a lung collapse will be having an absent breath sound or very minimum breath sound. This is the first difference that you can find out between these two. Lung collapse, there will not be any breath sounds on auscultation or diminished breath sounds. Whereas if you put this depth over the part of the consolidations, you will find out, you can hear bronchial breath sounds, right? Your vocal fremitus or whispering pectoral tube is going to increase in consolidation because the density of the lung has changed. It is allowing the sound waves to travel more easily, more distinctly. You can hear those sounds on auscultations. Whereas If you check for vocal parameters or whispering pectoral Q with your stats on a lung segment, collapsed lung segments, you are not going to hear anything properly. So this is the
Right.
main difference. And consolidation, you see air bronchograms, and lung collapse, you cannot see that air bronchograms.
Right. And actually, you have answered part of my next question that I was going to ask you, and that was apart from chest X-ray, what physical examinations do you rely on for diagnosing a pathology?
Yes.
And does it help? And does it help, or an X-ray is sufficient for an experienced clinician?
X-ray is not always sufficient. Even if clinician is very experienced, at times he or she can have doubts in their mind. To clear these doubts, we have other tools. If you have doubt that this is a pleural effusion, you always go for ultrasonography of that particular patient.
Mhm.
Ultrasonography tells you about exact location of the pleural effusion, the amount of fluid that is present inside the pleura, and sometimes you can go for CT thorax even if you have doubts. So this is an example of ultrasound where it can detect pleural effusion and it can also detect a lung collapse. You go for CT thorax. CT thorax can also tell about lung collapse. CT thorax can tell about everything. If you have any doubt, you can go for CT thorax, but CT thorax is very expensive. So generally, ultrasonography is done to find out some of the abnormalities.
Right. Uh, and just for students, would you like to mention anything that generally is a mistake in interpreting chest X-ray and should not be done?
For students, first thing is that during our BPT level, I'm not sure whether this chest X-ray interpretation class is being taken or not. That is first thing that has to be done. During their internship, they should go to these hospital setups to see more and more of chest X-rays, and they should be taught about chest X-rays. Then only these abnormalities can be detected easily. But of course, when we were students, when we joined this institute and we were freshers, we used to do a lot of mistakes. So you need to have a proper guide who can tell you the mistakes which you are making, because it is
Right.
not very easy to understand between the differences between a collapse, a consolidation, and a pleural effusion. Sometimes even we, after knowing or working with this institution for 14 years, we also commonly do a lot of mistakes. So it's not easy. It happens with time. The best thing is to have choose a guru or a proper book or listen to
Mhm.
presentations like this to find out the
Absolutely.
differences, and gradually it comes.
Absolutely, Dr. Bodhottom. And thank you for this wonderful lecture and an insight on chest X-ray interpretation. I hope that the fraternity learns a lot from this. Thank you.